Good day to everyone. My name is Bongilex Melane, Senior Nurse here at Hospice at Home. May I welcome you all in this today's session. It's a Eswatini Eco. I would love to pass just a few remarks on our members who always join the meeting with us. I would love to upload Eco India for the support. They've been here they've been supporting us through and through. Thank you for the other parties, our folks who have been with us now and again. Thank you to our professor who's been with us, and even today he's with us. For this moment, I would love to ask for a brief introduction by our Eco Eswatini staff. Just a brief introduction. I'll start by you, Mr. Kumare.
Good day, colleagues. I'm glad to be here.
Good morning, I'm Benedict Damini from Eswatini Hospice.
Good afternoon, colleagues. My name is Samuel Olukele, Eswatini Hospice at Home. Okay.
Afternoon, colleagues. My name is Sandile, Eswatini Hospice at Home Eco Coordinator.
Good afternoon, colleagues. My name is Nidhi Martin from Hospice. Good afternoon, colleagues. My name is Luana. Good afternoon, colleagues. My name is Nisha. Good afternoon, colleagues. My name is Madame. Eswatini Hospice at Home.
Thank you for your introductions. At the moment, I would love to ask Maga Zodwa. I'm seeing you there to please introduce yourself to the group.
Thank you, Tim. Good afternoon to everyone. I'm Zola Kamete, Eswatini Hospice at Home. Thank you.
Thank you, Marita Menze. I would love Malaika to introduce herself to the team. Hello, Malaika, are you there? Malaika, are you there? At the moment, can I ask Mr. Professor Wilson, can you please introduce yourself to the ECO team, Eswatini ECO team? Professor Akunda, are you there? Seemingly, maybe they haven't.
We don't hear you. We don't hear you, Prof.
Professor Akunda, can you please unmute yourself and introduce yourself to the ECO team?
Please unmute, but we can't hear.
It means we are not connected to him.
We are not getting you, Professor. I don't know what is your connection on your side. In this side, you are not audible.
Okay. Can we go ahead? At the moment, can I introduce a small recap for last time? Okay. I'm seeing Sister Felicity Mukele. Can you please introduce yourself, Sister, to the ECO team group and the rest of the team? Sister Felicity.
Hi, good day, colleagues. Long time. I'm happy to join you today. Although I'm on my way, I'm Sister Felicity Lukele, sister at Palliative Care, Mbabane Government Hospital.
Thank you so much, Sister Felicity. We are so excited to be with you today. It's been a long time, yes. Last time we had a session which was on physical treatment approaches for pain management in palliative care. It was brought to us by Mr. Sandile. It was a continuum session on pain management. He reminded us that there are rules which we should follow in pain management when we approach pain. He talked of the non-pharmacological treatments, which is we can say the physio, the cognitive. He also said we should be treatment should be multi-dimensional, and the use for it should be preference and the effectiveness. And he taught us that this is individualized. He also highlighted that these therapies could be cold therapies where there is somatic pain and exercise, those activities, heat therapy, vibrations, but with the vibrations we said we shouldn't give those therapies to soothe the pain in people who are on radiation or have extremities that have blood clots. Let me rest the case there. But before we continue to our next didactic session, may I remind you, colleagues, that we should put our gadgets on silence, and at least maybe they should be muted. To communicate, then we ask you and request you to unmute or else raise the hand or use the chat box. At the moment, I'm sure I have to give Mr. Sabelo Kele from Eswatini Hospice at Home, who's going to give us a session on mind-body treatment approaches for managing pain in palliative care. Welcome, Mr. Kele. Over to you.
Thank you so much. Once again, colleagues, good afternoon. My name is Sabelo Lukele from Hospice at Home. Today, I'll be taking you through today's session, which is mind-body treatment approaches. This is one of the non-pharmacological approaches that we do to our patients, which normally does not include drugs, but it's a non-pharmacological approach that is very special and powerful, that can aid to our services as we do our services in our communities, in our facilities, to our patients. So, in introduction, the mind and body practices are a large and diverse group of procedures or techniques that are administered or taught by a trained practitioner. Bear in mind that these approaches are not just done by a lay person, but it needs to be a trained practitioner, health practitioner, to conduct this kind of services. It is also a type of complementary and alternative medicine. Also, it is called, sometimes it's called a mind-body modality. So our examples here, what we'll be talking about today, we'll be talking about the biofeedback approach, counseling, cognitive behavioral therapy, which we commonly call it CBT, Also, there is music, which plays a very important part in pain management. Prayer, also, we will talk about it, and relaxation and meditation, yoga, and lastly, we'll talk about the Tai Chi. In biofeedback, this cognitive approach involves training of the mind to respond to physical feedback in a way to direct physiological functions. For instance, training the mind to consciously influence heart rate, respirations, or heart tension. In that way, it alleviates pain. Also, it is not recommended as a singular treatment strategy for pain, but it is recommended as an additive strategy with a cognitive behavioral therapy program to facilitate exercise and return to activity. So also on biofeedback can be very useful for those with headaches and other forms of chronic pain involving muscles, because the individual here can learn how to consciously relax muscles, tension, and reduce guarding or bracing behaviors that tightened the muscle groups. So the counseling here usually it is usually done by the social workers approach, a psychosocial approach in pain management, a strategy that assists the individual with coping. So it helps with coping mechanisms. This counseling, because it's not a once-off approach. It's an ongoing service that we need to conduct to our patients. So communication here with a professional counselor helps the person manage their chronic pain rather than having the chronic pain manage them. So the counselor here can employ a variety of techniques to assist with reflection and problem solving, so that the counselor can assess that the approach is successful or is effective to the client. The techniques may include the ask, tell techniques, can also aid to this kind of a service to this patient who is having a chronic pain. In cognitive behavioral therapy, which is CBT, is a type of behavioral intervention. This type is recommended for treatment of chronic pain and should be strongly encouraged. Why? The central idea in CBT is that the person's thoughts and beliefs, moods, and emotions all influence the perception of pain. So the pain here, it depends on the patient. The perception of pain here depends on the person's thoughts and beliefs to manage those chronic pains. Then CBT, this cognitive behavioral therapy also works to enhance coping skills, increasing confidence, and changing how someone responds to that particular pain. The identification here and the reinforcement of coping skills is likely to more useful than ongoing medication or therapy. So another part here, which is very important, is music. Sometimes it works, sometimes it cannot work, depending on the intensity of the pain. It's known to be powerful and influence the mood. Current evidence supports using music as a sensory intervention to soothe and relax, energize and uplift, or it acts as a distraction. So when an individual experiencing chronic pain seeks a non-drug strategy to help minimize pain's perception, choosing favorite music here selections is common. So a patient here can choose which or what kind of music that she or he prefer, or to ease or to alleviate the perception of pain. So there are also educated music therapists to assist there that can design musical intervention specific to likes and needs. The therapy might include listening to music, making music. Sometimes you can do it by songwritings, meditation to music. There are those kinds of music that helps in meditation. Using music to form images in the mind as a form of distraction. So by so doing, we help the body, or we help the pain here to be alleviated without the drugs or without the pharmacological approach. Then prayer also plays a very important part here. It has many definitions and takes on many forms, but it is basically a conversation between the individuals and the greater than human spiritual being. So prayer is not just a prayer, but it's a concept. It's a conversation that can distract one's body to alleviate pain. Prayer is a form of meditation that is generally quiet and introspective, although it can be part of a more public spiritual ritual. So it's a very common non-drug approach to pain management, used mostly to assist with coping. The power of prayer performed silently or out loud. Sometimes it can not only mean that you have to climb on top of the roofs and yell and shout for God to hear you, but it can also be done silently. So it is about the profound feelings and sense of spiritual connection that offers some serenity and a hopeful perspective. Prayer may also or may not relieve pain, like I have mentioned before, but it often produces an improved outlook and sense of hope. Few research studies have been designed to measure its effectiveness, but those who engage in prayer usually report that doing so is so helpful. Relaxation and meditation. These are also techniques or also approaches that assist the individual with strategies to redirect attention, distract, and focus away from the pain. So by so doing, you are relaxing the muscles, you are taking the mind away from pain. Meditate on something else just to distract so that you cannot feel the pain. Techniques such as guided imaginary, cognitive distracting, and cognitive reframing are typically used by the therapist, teaching an individual how to improve control over the overall pain experience. They can be introduced and then reinforced as non-pharmacological strategies to reduce overall pain. Then the yoga, it also helps because it is also part of relaxation of the muscles. It helps to manage chronic pain by stretching, relaxing, and strengthening the physical body using intentional movements along with controlled breathing. So known benefits include a general sense of well-being, more restful sleep patterns, increased ability to handle stress, and also proper body alignment. And there is that last approach here, which is an ancient Chinese system meditative movements that are practiced as exercises. They enhance harmony between the mind and the body. So people of all ages and body types can participate in this approach. It doesn't matter of the age, even if you are young or old, you can practice this approach. You can participate, and it is recommended for those living with arthritis, low back pain, and fibromyalgia. Tai Chi is appropriate for everyone at high risk for falling, because the route, choreographed movements and stances promote strength, flexibility, posture, and balance. So in summary, as we are summing up this session, the comprehensive pain treatment approach should include a variety of non-pharmacological treatment options. So it is not only the pharmacological approaches that are needed to manage pain, but also this kind of treatment, or this kind of pain management are also important. So neuropharmacological interventions have a similar effect as pharmacological interventions. So it has similar effects, even if we are using the pharmacological part or this route, the effects are the same, and should always be individualized and patient preference. And what is most important here is the documentation, so that the next person can see for further management and for continuum of care. So this marks the end of today's presentation. Thank you very much, colleagues.
Thank you, Mr. Bukele. Thank you, Sabelo, for this beautiful presentation. At this moment, I would love to maybe highlight that this is almost a continuation of what we got in our last session, because Mahlangu was giving us the non-pharmacological, and he even said that it was not the only examples he gave us in the last session, but today I'm so glad that there is a continuation, which also sticks to the same thing, that the non-pharmacological should always be individualized and patient preference. And today we learned that these approaches should be done by someone who is a professional. And as we look at one of each examples that he gave, the bio, the counseling, the CBT, the music, the prayer, the realization, and the yoga, the TAT is something that we should go back and look at our principles of managing pain, that we should start by the non-pharmacological management, and then we go step by step. I think, let me wait there and open the platform for any questions and inputs and questions. Thank you. Over to you, colleagues. Any inputs, any questions?
Let me
The
input
floor
you.
is yours, colleagues.
Maybe I can add something, maybe even colleagues. It's a blessing today. We also have Mpumi with us who specialized on this psychological and spiritual care. But the issues maybe I think that Mr. Kelly emphasized in terms of in these non-pharmacologicals in adding to our physical management. I think the issue of spirituality is very key because I have one patient who I once saw in our patient department who was under the Jericho Church, and he has this stage 3 eye cancer and was on opioids. But then by the time when he came for pain management after he has tried to look for opioids in his nearest facility, but he couldn't get. So he came into our facility to get those pain medication and dressing supplies. So one of the things I asked him how he coped with the pain. The patient said that one of the things he used to deal with the pain is that he prays. And he's told me that after he prayed and then the pain subsides or he feels better. So that shows that really helping our patient to deal with these issues, they are then able to deal with the pain. So we need to work on those issues. And even the music also help us do that. So I was just emphasizing that. Also to know the patient's spirituality in your interventions will also help. Also knowing that how the pain is affecting the dimensions of the patient, especially on the psychological, spiritual life, will also help you to know the strengths and weaknesses of the patient, and knowing those strengths that will help the patient focus his mind on the on life and distract the pain. You will discover that he is making it through. I can see also on chat, I see Professor Kunda writing that in addition to the 8 points that we mentioned there, other psychological interventions include management of depression and anxiety, and both worsen pain and cause anxiety, and also depression, and also management of insomnia, which worsens pain, and pain worsens insomnia. So normally these are the aspects of pain, the psychological, physical, social, and spiritual. One affects the other. So I think Professor is echoing that. If the patient has psychological issues, they will end up exacerbating the physical issues, the physical pain. And if the physical pain is there, it will exacerbate the other. So managing them, it's also very important. So I think knowing how the patient copes without relying maybe on those drugs, by then looking at the non-pharmacologics, some of these issues also helps a lot. And that would be my input in terms of using mind and body therapy, because the rise and fall of the patient is on perception, on how the patient perceives himself. Once the patient feels small, feel less of a human being, feel stigmatized, feel less, feeling unable to cope, you find that they are unable. But then when you build on their strengths, using what they prefer to rise on or to cling on, you'll find that if you promote it, they are able to overcome those psychological perpetrators behind the physical pain, and you'll find that they are able to manage. And you will discover some of the time we will need less of the pharmacologics. We will end up reducing the polypharmacy issues and running away, and will prevent them even in misusing the drugs, or in even ending up using substance, being under substance use disorders. So I think harnessing on our non-pharmacologics also will help us, especially dealing with the mind of the patient.
Thank you, Mr. Machamu. I'm seeing your hand, Marie-Damini.
Thank you so much. Thank you, Mr. Kelly, for today's lecture. We are happy for being trained to manage our patients holistically. What I can say is that most of the time our patients come to our hospitals for healthcare settings because of physical pain. But then as they go on with the treatment, the physical pain is always worsened by the other pains, physical, psychosocially, and spiritual pain, which is why we always need to be diverse when we are managing such pain, not only concentrating on the physical pain, because most of the time the physical pain is taken care of by the pharmacological actions of care. Then comes the non-pharmacological actions whereby we need to use the multidisciplinary team approach, where most of our team members are not the ones that are prescribing medications. We find that most of the time they just sit with the patients, teach them, train them, counsel them, and such pain is always controlled. We are thanking you so much, Mr. Ken, for today's training, because we have learned that there are so many ways of managing such pain. So that is what I can say for today. It's just that we need to always make sure that we are a multidisciplinary team, and everybody has to play his or her part when we are managing that pain, because always our patients are not always suffering physical pain. They are suffering from all the other pains that most of us are putting them at the bedside. We're always concentrating, especially most of us nurses. We are always concentrating on the physical pain, whereas the physical pain is always taken care of at the first days, the few days that the patient is admitted into the.
Thank you, Marie-Damini. Thank you, Professor Wilson, for your input. Thank you, Marie Felicity. You are saying also look into the precipitating factors of the pain and advise patients how best to avoid to be exposed to them. Thank you so much. It's a strong point. Without much further ado, let me say let's digest on any question, any input, but you can also put it on the chat board. Let's go ahead and go to our next agenda. Case presentation by Ms. Tani. Last time we had a case presentation from Manzini Hospital by Nurse Nonsigelo Ntuli. I wonder if Nonsigelo, you've got any comments or anything you'd love us to maybe update us on anything from your case which you presented last time. Can I give you something like 5 minutes? Over to you, Nonsigelo.
Afternoon, colleagues.
Afternoon.
Okay, concerning our case we presented last time, we were with the client. He said that the pain is now decreasing, and it's on and off. He is no longer taking the pain medication every day. That's all I can say. Thank you.
Thank you, Sisi. Thanks for your efforts on this client of ours. Can I give this moment to Ms. Nduzo? Over to you, Sisi.
Good afternoon once again, colleagues. Good afternoon once again, colleagues. As mentioned by Mrs. Molane, your presenter today is known to the time for the whole region. National Because of Time for the whole region. Our client today is a 43-year-old female. So our client is a follow-up, it's not a new case, and our client has a breast cancer. So the main problem with our client is that the client is experiencing increasing pains as the illness progresses, and also with the arising complications, but she does not believe in the use of Western medication. So our concern is that there is need for assistance with other non-pharmacological pain control strategies, and also we need assistance with how to maximize the positive results on the current strategies that are being used. Because currently she sometimes has pain flare-ups with the current management we have. So on brief assessment, the chief complaint is that the client has a need for a prosthetic breast fitting. She also has increasing pain levels that can no longer be controlled by non-pharmacological techniques which have been employed so far. And also our client has a fear that if she starts pain medication, it might trigger her addiction to substances and cause her to relapse. Yet she has been clean for 4 years counting now. So on assessment, physical assessment, the general overall health status of the client was normal. She's had a left breast mastectomy, which means where she had the left breast, there is just an incision now. She no longer has a breast. So, but now she has small, lumpy, painful growths on the incision area, which are just scattered at least 5 or 7 centimeters apart. There are 3 or 4 on the incision area, which the client said they are painful. Otherwise, the incision was healing well. The client also has a pathological fracture on the left leg midway, which she sustained after beginning chemotherapy. So she has a plaster of Paris to maintain the bone in position while it heals. So that means physically she has restricted movements as she has difficulty with weight on the leg, resulting in need for assistance with some of her activities. Emotionally, the client seems to be coping well, though she did verbalize the need for prosthesis breast, as now she has only one breast, and it's such that it makes her feel non-whole as a woman. But then she has several coping strategies which are positive for her health. They include relying on her family and friends for support to manage any emotional distress. So socially, our client is able to adequately interact with family and friends. They are supported through her healing journey. She relies on her family for financial support to meet daily basic needs, that is inclusive of rent, food, medical bills, and they also support her son. She's also able to attend regular meetings with other clients on treatment. So the meetings are scheduled monthly at a local clinic. So on the spiritual assessment, our client's belief system was deemed positive for her health. She verbalized that she's a Christian and she's able to continue doing the activities that strengthen her belief and bring her closer to God even with the illness. She also attends, also church members, they do come to check on her for a prayer session whenever she's been unable to attend church that Sunday. So the medical history of our clients is that she is a non-HIV positive client who's been on ART since 2016. She is currently on her 5th cycle of chemo, and she has a history of admissions in the rehabilitation ward, that is in the year 2000 and in the year 2003 due to excessive substance misuse. So when asked to list some of the substances she was misusing, she counted alcohol, marijuana,
tobacco, and also the use of other unhealthy concoctions where they mix ARVs with some other stuff, those things. Also, she has a left breast cancer. She's also had a mastectomy to remove the cancerous tissue. So relevant past medication for this client included amitriptyline, haloperidol, and aten. So currently she is taking her ART regimen, which is tenofovir, amivudine, and dolutegravir. She's also on chemo. She's also taking the supplements ferrous and folic and isocas. So with the pain assessment, the first pain, which is located on the left leg, the client advised that she's had 3 months with the pain and it is dropping at a scale of 5. It is intermittent. It is usually caused by when she tries to regulate, when she's stressing or doing any other daily activities. And also the pain does affect her sleep and it also partially affects her mobility. So the current techniques employed to control the pain have only been able to achieve partial pain control. Then with the second pain, which is on the breast, on the left breast incisions where there are these lumpy growths I mentioned. She's had this pain for a month now. It is burning, searing, and stabbing at a scale of 5. It is constant and it is usually precipitated by touch, especially when she touches herself during bathing or when clothing touch the area. So usually she is relieved by hot and cold water therapy. It does affect her sleep, but it doesn't affect her mobility. And also we've only been able to achieve partial pain control with the non-pharmacological techniques. So reviewing the patient, she was reviewed on the 18th of May. She had just returned from hospital after a tooth extraction and was in pain. She had difficulty talking, but she did realize that the non-pharmacological pain techniques seem to be no longer working adequately to control the pain. With her social history, the client is unemployed. She and her education ended at Form 5. She is currently singing. She belongs to the middle class. And with the lifestyle habits currently, as she verbalized, she said there are no harmful habits currently, but she does have the history of the substance misuse. Relevant conditions in the family members include that the mother passed away from cervical cancer. The client's father has hypertension and diabetes, and also that some of the close relatives are still misusing substances, which make it harder for her to stay clean. With the advanced directives, we have it done early, and inclusive the living will also didn't do it, but her mental status was assessed and she was found to be normal. Her vital signs, her BP, they were all normal, but the pain score was at 5. Sometimes she does have the flare-ups where you find that she said it's up to a 7, but most of the time the pain is at a scale of 5. And her epoch functionality score is 3 because more than 50% of the time she is in bed or in a chair. Some other symptoms that she has, except for the pain, is mild anxiety and also the severe poor mobility. We couldn't do the lab investigations. So then we're coming to our further plan. Can we note, colleagues, here that with the further plan, we've also included already some of the non-pharmacological activities we've been educating and assisting the client to perform, which means it will be an ongoing process. So that's why I included them in the further plan. So physically, the plan is to fully explain to the client how substance addiction comes about, especially with the use of Western medications, which in our case is the opioids. and also allowing the client to know that it's okay to change her mind whenever she feels the need to, because currently she had said she doesn't want Western medication at all, but we want to give her the allowance that it's okay for her to change her mind, and whilst also supporting and respecting her decision to not use any Western medication. Then we will also continue with educating the client on general health promotion measures, and to also continue with the non-pharmacological pain control techniques like the yoga, hot and cold therapy, the distraction techniques. She said she watches television and tries to read books in order to distract herself from the pain. And also she surrounds herself with loved ones since they come during the day to visit her. And she also tries to do mindful meditation, although she said she can't do much of this one because the area where she lives is not that much quiet, yet she feels she needs a quiet area to be able to meditate and not be disturbed. And we are also going to try a new technique called guided imagery, where the patient, when she is calm and collected, she is able to control her thoughts and is able to imagine herself in a place which will bring a sense of peace and calm to her. So she would have to be able to imagine all that in her mind so that she's at least distracted from the pain. So we are yet to try that method. And we've also referred her to a primary care provider for thorough examination or for the lumps on the incision area and for continuous care. So today morning, our client called and said she did went to the doctor, who examined her and said that she will be scheduled for a surgery for removing the lumps. Then she will have to go to South Africa through the Palliative for radiation, so that if there are any remaining cancer cells that they. So emotionally, we will continue to reinforce the client's current support system and strategies. We'll also encourage her to verbalize her thoughts and feelings, especially on the having the one breast, since she did highlight that she no longer feels whole enough as a woman. And also to talk about her thoughts and feelings with regards to the body image change. Then socially, we'll reinforce her current social system the client already has, and continue to include the family members in the client's care whenever possible, because the client's family is very supportive. Spiritually, we'll continuously assess her sources of strength, hope, meaning, peace, love, and connection. And then we will further explore her spiritual beliefs and the client's health. And we'll also strengthen current spiritual activities, because as much as we have been with the client, and she did verbalize that she's Christian and she does go to church, but we haven't delved deep enough with the spirituality of the client, because she also has those hints where she feels like in the past she was a person who was going about life as a sin, especially with the drug misuse. So we are still yet to talk further on the feelings on it. So our main problem or concern was that from you colleagues, we just need assistance, that this client, she doesn't want anything which is a tablet or a pill for controlling the pain. She just wants this non-pharmacological techniques. But currently the ones we've been using, they are no longer that much effective. So that is where our problem is with today's client. Thank you.
Thank you very much, Ms. Tani, for such a wonderful case presentation. It's so exciting, and to know that what we've learned today, we are seeing it on your patient. And it's more than 3/4 of this non-pharmacological pain management I've seen on that case presentation. Can I give this moment to any of the colleagues to comment and maybe look into what else can we do to help this kind of hours. Marishamini, you have a head on.
Thank you very much. My question was that where is the patient getting at medication? Because by knowing where she gets the medication and trying to find out how they manage to get her into taking the medication, maybe we could get a point, an entry point to making sure that she's getting some pain medication. If we can work with those people that she's getting the medication, the art medication, we could even start in.
Thank you, Marishamini, for the question. So the client, she doesn't really have a problem with some parts of the Western medication, especially like the supplements she is taking and also the art. Her main problem is with the opioids because she fears addiction and she also fears that with her history of substance misuse, she fears that pain medications she had that they are addictive. So we've also tried educating the client on that. Otherwise, her art, she gets it from Mochane Clinic. That is where she is also getting the support group. So it's the support group of other art patients who meet monthly to encourage each other and give each other tips here. Otherwise, that is a good point to also try to start as much as we have to respect the patient's wishes.
I want to just to follow up that she has a support group. Maybe if we can go back to the support group and find out how the others are taking the issue of use of opioids. You might find that there's so much pressure that she's getting from the support group that she's always. Maybe we can take some time to maybe visit them once, maybe just go and sit in there and listen to how they speak to each other. You might find that there is a big problem with it into her only or direction or her only path. And by the way, you find that maybe the problem is really big. Everyone in that support group is having the same problem with opioids. The morphine taking is an addictive thing, and also the family that she said there are some people in the family that are still using or abusing some drugs. Yeah, I think we still have a long way to go with our patients, trying to explain to her how the pain and how the disease, as the disease progresses, how does it influence the pain that she's experiencing and how the opioids are working. And then we have a family meeting where we involve everyone and ask them how are they taking it and how is their, how can I say this thing? But I think we also need to involve them actively, not that they only look at the part that we are taking care of the patient. We also need to take care of the whole family. Because as you have said that even some of the members, they are drug, what do you say? Drug addicts or drug misusers. They misuse the drugs, and which drugs are they normally misusing? And even in the arts that she's continuing to take, she's aware that she has been using it, combining some other drugs to make that thing. Maybe if we can just get with that part, we can go a long way and find that at the long run, we can get her into taking the pain medication and she's pain-free and the quality of life is improved. Because that is what we are all about.
Yes. Maybe to add to what Umelo said, I think one of the things I'm picking from this patient is that there's a lot of myths around the opioids because yes, he is a risk patient and a patient who's at high risk of substance use disorder. And before maybe we think of initiating him into the opioids, the initiating facility will need to do the OPT so that it can be done. And then the patient will need to be closely monitored, because looking at, for now, it might seem like he's running away from the past life of drug abuse. I think one of the other things is misinformation that she has concerning opioids, or else she knows how opioids works. And maybe she has used them maybe somehow back, so she's scared to take the morphine again and go back to the old life. She thinks now as a Christian, God is punishing her for that's why she's going through this pain. I think those are the issues we need to find out in terms of his understanding of addiction and the opioids, and how come she knows what knowledge he has about the opioids and addiction as he's citing, so that those myths could be cleared. You will find that she has an experience in it, because sometimes patient experience with drugs and opioids will hinder them to take them again. So maybe then the education in terms of the assurance that taking the opioids for pain will help ease the pain other than the addiction will then a little bit clearer. But I'm suspecting there's some information or there's a knowledge about the opioid, but there's misinformation that if it's taken for pain, she will not go there. And even she's scared of going back to that addiction. I think giving her the assurance that there are health professionals who will initiate him to these opioids and he will be monitored, then the close monitoring, and if it's called for the rheology to be done, the urine test should be done as required or as needed for her, as long as she will comply with the opioids. But for now, taking out, then refusing the opioids means there is a perception towards the opioids other than the Western medication. He could mean that. And there's a possibility now he will be taking Panadol one way or the other, and he will be at risk of liver problems very soon. Liver toxicity will catch up with him. I'm not sure if he's not taking this common drug that we have in the country, the steel pain or the paracotin, because that one will destroy her, because having this severe pain with the flare-ups, it means there's a lot that is happening. And you will find that as the cancer progresses, the pain will go deeper and you will feel withdrawal. I think healing is spiritual, because blaming yourself, feeling like God is cursing you, is another area that she needs some. If you need a spiritual chaplain or a pastor who will help her understand that God cannot punish her for sins she did before or things bad he did before. There's no way God can punish her for that. I think she needs also that assurance that no, it's not God punishing her. I think she can do something. But then before initiation, the OPT will need to be done, because she's a high risk in terms of opioids. And then even assessment of the family lifestyle will help to know how is the family system. Are they not using these drugs? If they are, how safe is our patient when we initiate her to opioid? Because she might be scared of going back.
Thank you very much. Okay, darling.
Thank you very much. Yeah, I think as Mr. Matama has said, after doing all those things, I think we have to first come from the part where she's most strong. She's so spiritual that she says every time she prays, and church members always come when they haven't come. When she hadn't gone to church, the church members come to check on her. I think if we can get on that part and ask more as to how are they treating her, are they always maybe because some of us Christians always refer to the patient as that one who has been taking drugs, that one who's an alcoholic. Even in church, we refer to them as the one who's been taking alcohol, the alcohol, the drug addict, or the bottle. If we can only get on that part and understand how their relationship is, and even their pastor or whosoever is the head leader, the spiritual leader, how is her relationship with them? And how is his or the church understanding concerning the opioids and all those things? Because you may find that they also put pressure on her not to take the drug because they know her as the one who has been using. She might relapse and go back to that one. We will start to address the issue spiritually, and then we go. We might try to get the
We have a comment from Dr. Professor Akunda saying, in my experience, non-pharmacological methods alone are not very effective in management of cancer pain. They are most useful in chronic non-cancer pain. In cancer pain, non-pharmacological interventions are used as adjuvants. That means supporting the pharmacology. So we have a synergistic effect. So I think that's one of the things she needs to understand too, that she has got cancer, and cancer pain is not well managed with the non-pharmacologies. She needs to have something to be supported by the non-pharmacologists, and giving her the assurance that taking the pharmacology or the opioids, especially for the severe pain, will not mean she doesn't have to do the non-pharmacological intervention. She's doing the prayer, the other things she's doing, but to deal with it, I think that one, or else even the benefits of taking the opioids in her situation, I think she will need that information. Thank you so much, Prof.
Thank you.
I'm just concerned about the caregiver. Is she always with someone who is a caregiver, or she's always at home alone? Because we also need to educate the one who's always with the patient. Some issues, especially the one that is not into doing this. Because if we can get to educate the caregiver, and then the caregiver who's always with her when we are not there, will always emphasize on what we taught on that visit. Every time we make sure that the caregiver is on our side, we leave the caregiver with more information so that he emphasizes the. This if we only attend to the patient and leave the caregiver out. Most of the time, our caregivers, when we arrive, they have the time to go out and wash and do their other things instead of sitting in and listening.
Thank you so much. Do you want to say something this time? Okay. Thank you, Mageshamini. Can I show you that Tani was taking the notes from everyone who made an input into our today's case presentation. Thank you so much to everyone. May I remind you, colleagues, that we need your feedback. We need your feedback. In our chat box, there is the where you have to click, and then we get your feedback. Can I also announce that our next session is on the 7th of June, 2023, and the topic is herbal preparations and dietary supplements for pain management in palliative care. Herbal preparations and dietary supplements for pain management in palliative care. Thank you so much for participating, and please do come back again. We honor and respect your presence. Thank you so much, and bye-bye to everyone.
Bye-bye, team. Please remember to click the feedback link before exiting so you can share your feedback with us.